Hi, everybody. My name is Jason. Can everybody hear me okay? Awesome. Well, I am a third-year resident here in the hospitalist training track. I'm originally from Massachusetts. Spent a lot of time in Texas, though, went to Texas A&M for undergrad, and I went to the UPL San Antonio Long School of Medicine for medical school. So we have a really exciting case for you guys today. It was actually the talk of the town around here for a while. So I'm going to ask anybody in the audience who is certainly involved with the care of this patient, or if you happen to recognize it early on, to save the surprise for everybody. But we'll go ahead and get started. So I'm going to present this case in kind of aliquots of information, and then I'm going to stop to let our discussants give their thoughts. So this case involved a 37-year-old man with presenting with a 4-day history of chest discomfort, GI upset, fever, and a painful lump in his armpit. He was driving home from work on a Thursday when he first noticed some chest tightness and discomfort. He took a shower and afterwards checked his temperature because he wasn't feeling well, and noticed it was 103 degrees. Over the next couple days, he had multiple episodes of non-bloody, non-bilious vomiting, as well as watery diarrhea. Then on Saturday, he went to an urgent care clinic with these symptoms, as well as some confusion and mental fogginess. His temperature there was 105 degrees. They did a respiratory viral panel and COVID tests that were negative. And then he was given IV fluids, antiemetics, pain meds, and prescribed a course of azithromycin and sent home.
Oh, actually, so it sounds like we lost Jason.
Home with post-outpatient follow-up.
Oh, Jason.
The next.
I'm going to have you stop right there and just ask the discussants.
Next step.
Amelia, what we might have to do is have Jason call in on his phone, which might be easier.
So.
Yeah. We can talk to our discussants while he does that.
Perfect. Yeah. So discussants, that's actually it was the perfect place to stop from what I heard of young patient coming into urgent care. What crosses your mind, or what are you thinking of, Evan?
So I guess I'd definitely like to get some more questions, but I think the biggest thing I take away from this is some like an inflammatory kind of spin to it. Certainly like the fevers, and then the painful lump. I didn't get where he said that it was exactly. Did he say?
In his armpit.
In his armpit. So that certainly could kind of map to some lymphadenopathy. But I think the big thing I'm taking away right now is inflammation, and then give a shout out to my roommate. He's made a mnemonic, but it's I've made, so it makes a lot more sense when he says it. But for inflammation, so I for infection, V for venous thromboembolism, E for endocarditis, M for malignancy, A for autoimmune, D for drugs, and E for endocrine. So those are kind of the things I think of for kind of an acute inflammatory process. And then also kind of the time course of this is like more acute to subacute. So kind of thinking going forward of what kind of acute, subacute things would be causing inflammation in this gentleman. The non-bloody vomiting and diarrhea is very non-specific and can kind of be a lot of things. So that's not something I would kind of anchor on right away, but I think kind of going forward, looking for other signs of inflammation and hopefully getting more from both his history and then kind of, past medical history as well and social history and all these other things kind of going forward. But I don't think we have a ton to go on right now.
Yeah, no, great. I love that you right away identify the inflammatory process that's going on and start thinking about what's on your differential, what you want to know, what you're listening for, what you're going to cue into.
Hey, Amelia, I obviously got kicked off, but I'm back with my phone. Where did I get kicked off, and what can I provide more information with?
Yeah, so we are just going through, Evan talked about an approach to inflammation, and I was going to check in with Hoda and Samara and see if they have any other thoughts. I think Evan gave a pretty comprehensive rundown there, and then have you continue with the course.
Yeah, Evan, I think covered everything I wanted to mention. With his age, obviously, yes, I agree with Evan. I want to know more about, past medical history, social history, a lot of those things. With his age and the kind of acute to subacute presentation, I think more about like infection, malignancy, autoimmune, those would be like higher, but like more of a systemic syndrome of like involving most organ systems at this point, based on what we're hearing.
Great.
Yeah, I really don't have a ton to add.
Awesome. Well then,
Evan, I think you have 2 roommates. Which one's making awesome mnemonics over there?
That's all credit to Jordan Williams there.
All credit to Jory Williams. All right. Fair enough.
All right, are we ready for some more info?
yeah, please.
So I'm not sure if this is where I got cut off, but basically the only other thing is on Sunday, this lump got worse in his armpit, and that's when he called into his primary care clinic, who advised him to come into the emergency room. So there's that. So then going through his past medical history, he has none. He has no chronic medical issues, major medical problems in the past. His only medications are actually what was prescribed at the urgent care clinic. So he's still taking his azithromycin. He has some Zofran, and then they also gave him some Norco. He's never had surgery before. As far as family history, one of his grandmothers on his maternal side had lung cancer, and then he had a maternal aunt with hypothyroidism. And then for his social history, he's a former smoker. He had 5 to 6 pack years of smoking, quit 16 years ago. He currently drinks 5 to 7 alcoholic beverages each night. He previously used marijuana, but hasn't used for about a month. And then he lives with his wife, with whom he's monogamous. He works as a chef at his ranch and has cats and chickens in and around his home. And there's an employee of his who frequently calls in sick. He thinks to avoid work, but that employee is currently out sick. Otherwise, no recent sick contacts and no recent travel. Is there anything else as far as exposure history that I can answer for you?
Jason, you might have mentioned that I missed this sexual history.
Monogamous with his wife.
And we've got a great question from Apoorva in the chat about how many birds does he have at home?
That's an excellent question. It always is. He does not have any birds at home.
Okay.
I did get that question from Jason John, my senior, when we were on the boards. I learned how to ask it right.
3 times, correct? At least.
I've heard good things about that guy.
He's okay. Another great question from the ACE team. Does you mentioned he lives on a ranch. Does he work on the ranch, or does he just hire that out? Any agricultural work?
Well, he does do some work around the ranch. Are there any specific concerns that you have with him working out on the ranch?
And anyone's
I think just to kind of that point is just like really trying to tease out what occupational exposures are. So like if he's from a respiratory standpoint, like is he actually like caring for these animals? Is he doing like a lot of raking or like any kind of other manual labor that would, put him from a risk of that kind of exposure? And then also just teasing out exactly what those animals are would also be helpful.
Well, that's a very interesting question, because it turns out that on Tuesday, so this is 6 days prior to presentation and 2 days prior to his symptom onset, he noticed that one of the ranch cats appeared ill. This cat had a lacerated black tongue and had a mouth full of dirt. And this kind patient tried to help this cat and tried to rinse out its mouth. In the process of doing so, the cat coughed some of its secretions into his own mouth and eyes, and he also sustained a scratch on his right forearm. They did bring the cat to the vet, but within 2 hours, the cat succumbed to its illness.
Actually, fair kind of confession, I did actually take care of this patient, but a fun little tidbit was the cat was named Batman, so.
Oh my goodness. So what we've got now, so people are asking about the cat scratch fever, or the cat scratch. What are we getting at? I kind of gave it away there.
Cat scratch disease.
Yeah. So that is absolutely on the differential. And what do we want to do, or what should we do next? Do we want to hear more about what this patient looked like when they came in? Is there other information we want before we go see the patient? Okay. So why don't we talk about what he looked like when he came into the ED, Jason?
Sure. So on presentation, he had a temperature of 99.9. His pulse was 122. His respiratory rate was 18, as it always seems to be. His blood pressure was 134/81, and he was satting at 94% on room air. His general exam was pretty unremarkable. He was alert and oriented ×4. We did take a look in his mouth, and he didn't have any oropharyngeal lesions. His neck was supple, and he didn't have any like stiffness or meningeal signs. He had normal conjunctiva. And then his cardiac exam was only pertinent for like a regular tachycardia. His lungs were clear to auscultation. His abdominal exam was normal. And then with regards to his skin and lymph node exam, he did have very large, poorly circumscribed, exquisitely tender left supraclavicular and anterior axillary lymphadenopathy with significant overlying soft tissue swelling, warmth, and erythema. And yes, he did have some scratches on his right forearm. But notably, that was on the other side of his body than these swollen lymph nodes and soft tissue swelling.
Okay. So I think at this point, I always find before you've seen the patient, you're starting to put those admission orders in. I really like to do a problem representation. So how about Hoda, would you be willing to kind of tell me what we know about this patient, age, how old he is, what's going in, and what we're concerned about? And then we'll talk about the differential, and we can start getting some of those labs back.
Yeah, so one-liner, I would say 37-year-old male with no pertinent past medical history, coming in with 4 days of constitutional symptoms, including like fever, nausea, diarrhea, with exam finding concerning for an infectious process. Exam finding pertinent. I try to keep it short, my one-liner. Personally, I prefer to keep it short.
I like it. So with that, I know we obviously have Bartonella henselae, cat scratch disease on our differential, but I really think it's always important to not have any premature closure. What other things do we need to evaluate as we start ordering labs and imaging for this patient?
Quick question about history. And I only think about it because we had another noon conference case last year about this. Were there any prairie dogs around that ranch?
Not that we know of. It was an alpine ranch.
Okay.
Why do you ask?
Yeah, the only known animal exposure was this cat.
The cat. All right. Because of plague, bubonic plague, that we've had in Colorado, because of the prairie dog population.
Excellent. Okay.
My understanding too is for the plague that it's often like ground squirrels or some, like they can be carriers for the plague as well, and not just prairie dogs. So still a possibility.
Yeah. And any other zoonotic infections that people have on their differential. I think kind of jumping to one of the really important takeaways from this case is animal bites and scratches are a very common source of infection, especially cat bites, even though they only represent about 10% of animal bites and traumas, they represent a disproportionate amount of the infections. So does anyone have a vague number of infections that they think about for cats, or?
Amelia, I'm seeing some really good stuff coming up in the chat.
Oh, perfect. Yeah.
On my phone.
Sorry, I can only focus on so many things. Spirotrichosis, awesome. Lymphoma, adenopathy, absolutely. Pasteurella, acute fever, tularemia, rabies, Hanta. Capnocytophagia, fantastic. Okay, so now I think we've got a pretty broad differential spanning all the way from lymphoma to all of those infections that we read about and learn about in Sketchy Micro and maybe don't think about again. So let's talk about how do we want to actually start working the patient up for these infections? What labs do we want to order?
So I am concerned about sepsis for this person. So I think getting additional just like baseline CBC, it'd be nice to see a lactate, like to see like just a CMP, getting some cultures, getting a UA, just kind of like the broad sepsis things. I think even though he's not complaining of any respiratory symptoms, getting a baseline chest x-ray as well.
Fantastic. So I will, let's see, I'll have Danny stop sharing, but let him keep typing in the lab values while we pull up the ECG, and I'll pull up the ECG and chest x-ray. I'll give you guys a minute to look at the ECG, and we can also start talking about what those original lab values are. Sorry, trying to find my share screen. Okay, so here is that admission ECG. Since Evan's in the hot seat a little bit already, I'm just gonna ask him to kind of give us his first impressions of it.
Just like a very brief, like not looking at too systematically, looks like probably sinus tachycardia. I'd have to go through a little bit more closely, but I don't see anything that's like jumping out at me right now.
Yeah, excellent. And I think this is one of those ECGs that you think overall he's a young, healthy male. He was having a little bit of chest discomfort, but it did not seem cardiac in nature. There's not anything, as you say, that stands out. And in fact, it is really sinus tachycardia, possible left atrial enlargement. And then we'll take a look here at that chest x-ray. Apoorva and CJ, since there's two of you, I'll let you guys work together. And let me know what you guys think about this chest x-ray.
I'll take a crack at it. So, you know, going through it systematically, it looks like a good exposure and not too rotated. The airway looks midline. The lung fields, I don't see any effusions. I maybe see some reticular opacities, like increased lung markings, extending farther towards the periphery than normal, but I'm not seeing any like large consolidation or any big changes with the heart.
Excellent.
Yeah, nothing to add.
Excellent. Any other thoughts from the audience? Dr. Connors, any other pulmonology pearls that you got for us?
Pulmonology stuff. Is Dr. Albert on? Because I think I see something he would like to comment. Is he here today?
I did not see him.
Okay, so he likes to talk about companion shadows. And I don't have a pointer to exactly show you, but a companion shadow, there's a couple of them in the body. The one we see most commonly is a reflection off the clavicle. Yep, and then you're pointing out the SCM shadows. And so the clavicular shadows are really hard to interpret. And here I would say that it's probably not too helpful, but the SCM is much more visible on the right than it is on the left. Exactly, there's a line there, and there's sort of this general haze here. I forget which side had the lymphadenopathy, but to me that looks like it could be lymphadenopathy. Obviously, clinical exam is going to find that, but I would say as a cool chest x-ray finding, I think that's positive.
Excellent. And they actually didn't comment on that, nor did they comment on this significant axillary fullness.
Axillary, yeah, the left axillary.
There he is.
Area, yeah.
Here.
Up here. You can actually almost see the lymph node in the left axilla.
Yeah.
It's not quite centered correctly, but you can certainly see the fullness, and there's almost a nodular appearance there.
Yeah.
But I'm sure you picked that up on physical exam.
Yes.
It was not subtle on physical exam. I can confirm that.
Yeah.
Wonderful. Well, with that information, in the time we got that, those imaging studies, we've got some labs back. I know we talked about initially we want just the CBC, CMP, UA, lactate. What do those look like for us, Jason?
Yeah, so just starting with the basics. BMP, the sodium was 126, the potassium was 3.3, chloride 92, bicarb 24, BUN 26, creatinine 1.49 from an unknown but presumably normal baseline, and then the glucose was 118. On the LFTs, the only really notable thing was mild AST elevation to 74 with an ALT of 34 and an alk phos of 132, but the bili and albumin and total protein were essentially normal. CBC showed a leukocytosis of 12.8. That was 83% neutrophils. Hemoglobin was 14.8 and platelets were 66. And then a lactate was 2.1. UA showed 4+ protein, 1+ ketones, 1+ blood, but no leukocytes or nitrites. And then blood cultures were sent and are pending.
Awesome. So I know we talked about a large number of other things on the differential. So specifically, we started with Bartonella henselae. How do we test for that? Yeah, I asked because it's something that we like. Oh, yeah, go ahead.
Yeah, I think we do serologies, right? Like
Yes.
IgG, IgM.
Exactly. Yeah, I asked because I think we throw it out as a diagnosis, but it's not something, it's actually a very fastidious organism that can be very challenging to grow. You need to keep the culture in pretty precise conditions for at least 21 days in order to start evaluating it from a culture. So you send off the serum IgG and IgM. Did we get those, Jason?
They're sent and they are pending. They will be resulting in the next 2 or 3 days.
What are there other studies that we can do in the meantime to evaluate this young gentleman with febrile lymphadenopathy, concern for infection?
I think we can talk to some of our colleagues with regards to a biopsy.
Excellent. Did we get any of those balls rolling with the admission, or what did that look like, Jason?
Yeah, that's actually a part of our next aliquot. Before we're going to do a biopsy, I'll tell you right now, we're going to do a biopsy. Are there any other labs that anyone else wants before I tell you about the biopsy?
We do have, Cassandra would like basic heme labs like a smear, LDH, calcium. There's a few votes for smear, as well as coags. And then I would throw out, again, getting back to a more general differential, thinking about causes of lymphadenopathy broadly. Important to consider viral lymphadenopathy. And consider serologies for the common viruses that can cause that, EBV, HIV. Perfect.
All right,
Maybe,
so HIV,
maybe Danny can share his screen so we can see all those numbers, because it's hard to remember all the stuff that was out there.
HCV, excellent.
That's good. Thank you.
Cool. Thank you.
So while you guys are looking over those, so coags were normal. A smear was essentially unremarkable. It showed, the thrombocytopenia. I think there were some Dole bodies, which I always forget what those are. And then HIV was negative and HCV was also negative.
Then did we get a syphilis also?
I'm not sure if we checked that, but for the purpose of this case, we'll say that it was negative.
He's had a -1 at some point. I can't remember exactly when, but since this presentation. Ooh, more rare differential to consider. Big teaser there. But in someone with signs of multiple end organ dysfunction and cytopenia, you can also consider HLH. Ooh. I don't think the VA has microphones, but are you able to share any more or any other thoughts that you'd like? Yeah, perfect. So serum ferritin can be very helpful with HLH.
Interestingly,
the nice thing about HLH. Oh, sorry. Go ahead, Jason. I was going to say.
I was just going to say really.
Yeah.
Go ahead.
You go.
After you, Dr. Connors.
I was just going to say it's a nice because the HLH is caused by something which could still be Bartonella or any of the other things we're considering. And so the HLH gets to go alongside and you get to play that game along with the still figuring out what this is.
Yeah, that's key. HLH isn't a diagnosis. It just tells you that you haven't found the diagnosis causing the HLH. It's either an infection or cancer, or rarely inflammatory condition by itself.
Wonderful. Okay, Jason. So we've gotten him tucked in for overnight, as many labs back as we can get. What happens next?
So on hospital day 2, as Dr. Levine alluded to, the patient did undergo an ultrasound-guided left axillary lymph node biopsy and was subsequently started back on azithromycin as well as gentamicin. They wanted to hold on antibiotics to initially to increase yield from the cultures from the biopsy. He also underwent chest CT with contrast, and that revealed diffuse soft tissue swelling, edema, and subcutaneous fat stranding of the left lateral chest wall, enlarged axillary, subcarinal, and mediastinal lymph nodes, and then a multifocal nodular opacification of bilateral lungs with a small layering left pleural effusion and mild splenomegaly. Gram stain on the tissue culture.
Here.
Oh, sure.
Yeah, unfortunately, I didn't also include the lung windows, but you can see the effusions there and kind of mediastinal lymphadenopathy. I can go back if there was any point that we wanted to.
Can you go back to the chest X-ray?
Yeah, absolutely.
Because there was a finding there that I didn't talk about. Look at the left costophrenic angle. And you see how it's displaced from the rib a little bit. Look on the right. Notice that the right costophrenic angle is absolutely exactly on the rib. But on the left, it's pushed in like a centimeter. And that's an indication that there's pleural disease or pleural effusion. So you can actually see the pleural fluid on the chest X-ray. I don't even in retrospect think that I can see mediastinal adenopathy, however.
Wonderful, thank you. Okay, sorry, Jason, go ahead. What else did we get with this kind of first round?
Yeah, so the tissue cultures on the lymph node biopsy showed rare gram-negative bacilli, and then 2 of 2 blood cultures from admission returned growing gram-negative bacilli as well.
Okay, so discussants, tell me about that. What do we think we have? Or anyone, not just the discussants. Anyone's allowed to talk.
Well, I think we were right on the money with an infection, so that's nice.
Yeah, okay, I love that. Yes, we like infectious inflammatory, big branch point, and there is an infection. What about the fact that we got gram-negative rods back? I know we were kind of thinking Bartonella. Is that consistent with what we were thinking?
Now this is like kind of pushing beyond my like remembering, but Bartonella I think is pretty finicky to grow. So it's pretty surprising that it would grow, if it was Bartonella, for it to grow so quickly. So that definitely makes me think that's not what we have here.
Yeah.
I'm gonna go back to my initial suspicion and say that I still am worried about plague. It is a gram-negative. Yersinia is a gram-negative bacillus.
Yeah.
I think Francisella is like gram-negative cocci, though, if I remember correctly. So it makes that less likely for like a lymphadenopathy type picture with the zoonotic likely source. So kind of like Hoda as well.
Sounds good. So we kind of and I think it's really important to understand not just what you're worried about, but how quickly you would expect a result. So I know we also, given how long it takes to get that culture data about Bartonella, we ordered those serologies. Are those back yet, Jason?
Yeah, so some of that stuff is starting to come back. So Bartonella, IgG and IgM was negative. Francisella antibody was negative. They also checked Coxiella, IgG and IgM for Q fever. That was negative. They checked Epstein-Barr virus. The IgG was positive, but the IgM was negative. And then because he was having diarrhea, they checked a GI PCR, which was negative as well.
Awesome. So what happened from there, and what did they go with?
Yeah, so early on hospital day 3, we're talking like 2-3 o'clock in the morning after he had this biopsy and chest CT, the on-call MICU resident was called to evaluate the patient for transfer to the ICU. The patient was reporting confusion, only oriented to person and place, and he said he was hearing voices talking to him through the radio. His temperature was 100.8. His pulse was now 142. His blood pressure was 147/98, and then he was sitting at 96% on room air. His exam was otherwise unchanged. And then we did get a whole new set of labs, which I am happy to share what people want to know. But essentially, his sodium was stable around 125. His creatinine was up a little bit now to 1.75. And then on his LFTs, most notably, his AST was up to 296, ALT 45, with an alk phos of 545. His white count now is 38.6, 88% neutrophils, with a normal hemoglobin, and platelets were actually up a little bit at 92. His lactate was 2.8, and it progressed to 3.6 on serial checks. And then the MICU team, as they were receiving this person's care, checked a procalcitonin, which was 42.6, and that peaked actually at 171.6. And he was actually transferred to the MICU for ongoing care.
Excellent. And what did we ever get speciation on those gram-negative rods from his blood?
We did. So I'm happy to reveal what we found. I was just wondering if anyone else had any other thoughts or final thoughts, because this is going to be the final diagnosis.
Was this patient ever put on precautions while like speciation was pending?
That's a really good autopsy on the cat. I know that there was an attempt to get it. I don't think that they were able to. But they did. I'm not sure when, I don't know if you know, Jason, but he was put on respiratory precautions, at least by the time of his kind of clinical decline.
Yeah, which is actually pretty easy to do in COVID. Everyone is on droplet precautions. And then, yeah, someone as sick as he was, I think once he got to the MICU, they kicked it up a notch with respiratory airborne precautions.
Excellent.
I want to ask a question about antibiotic use, because I think, you know, especially with all the applicants here today, thinking about, they can all imagine themselves being the person who's called with someone who's all of a sudden confused, fever of 108, tachycardia to 160, you know, the highest procal anybody's ever seen. Just the acute urgent management as opposed to even what this is at the end of the day.
Yeah. So what did they do for antibiotics at that point?
Yeah, so his hospital course from there, he was basically brought over to the MICU. He ended up being quickly intubated because of for airway protection. And then his blood pressure trended downwards to the point where he's actually started on pressors. Keep in mind at this point, he was already on azithromycin and gentamicin. And so they actually added levofloxacin in consultation with ID to cover basically all the things that are already on your differential. They repeated a chest CT, which actually showed progression of the multifocal opacities, as well as now a moderate sized left pleural effusion and a right-sided pleural effusion. And at this point, with the help of the Colorado Department of Public Health and Environment, the gram-negative bacilli from both his tissue culture and from his blood cultures were identified as Yersinia Pestis, confirming a diagnosis of plague.
Strong work, Hoda. You had a strong suspicion, even though there weren't prairie dogs. Excellent work. Thank you, guys. I always am like, oh, this is a tricky one. This is so uncommon. I don't know that they're going to get it. And every time you guys get to it, like long before I expect. So I'd love to kind of talk about a few different aspects of this case. I touched on some of them already, so I'll kind of go over those slides quickly. And then we have the other imaging. There's not really impressive findings, just the progression of the lymphadenopathy. And for time's sake, we'll skim through those. So I did want to talk today about what Bartonella henselae looks like and what that differential for febrile lymphadenopathy is. I think it's something that we don't see commonly, but when we see it, it's a serious problem that we do need to find how the systematic approach to and get a reasonable diagnosis as quickly as possible. And then I do want to talk about pathology and epidemiology of plague, as well as those clinical presentations and treatments. So zoonotic infections, I think, are on all of our minds these days for obvious reasons. And this case reminded me that zoonotic transmission has been a part of our life forever. I love this graphic from the CDC. It has every domesticated animal and some undomesticated animal talking about where these infections come from. As we mentioned, cat bites are one of the most common causes of infection leading to hospitalization in adults in the United States. And risk factors that put someone at a higher susceptibility for hospitalization due to a zoonotic infection include immunosuppression of any kind, a bite on the hand or foot, vascular lymphatic compromise, or a history of prosthetic joint at the site, as well as crush injuries, puncture wounds, or a delayed presentation. So anyone who's coming in greater than 12 hours after they had a wound to anywhere on their body and greater than 24 hours to a facial wound. You've got a little longer for the face because there's so much vasculature there. So Bartonella henselae, as we discussed, it's very fastidious, very slow growing. If possible, you want to collect it in one of these special tubes and incubate it for at least 21 days if serologies are not available. Classically, it presents first with a cutaneous lesion that then progresses to regional lymphadenopathy at about 2 weeks. It's most often present in children. And I think the important thing here is also not only the timeline for growing the bacteria, but the timeline for the presentation of the lymphadenopathy. It does typically take a couple weeks from the bite to the point of presentation with illness. Typically, it's actually self-limited. However, in some individuals, it may result in a visceral organ involvement, especially hepatic or splenic hypodensities that are visible here on these CTs can also lead to many ocular manifestations and CNS involvement. In individuals that have lymphadenitis that's persistent, you can treat it with azithromycin. And then disseminated infection is typically treated with azithromycin or gentamicin plus rifampin. So I think it's reasonable to think that the outpatient provider was not only treating for maybe a community-acquired pneumonia, but potentially this Bartonella henselae at our patient's original presentation. At the same time, as we mentioned, it's really important to have that broad differential for fever and lymphadenopathy. Everything from bacterial adenitis, mostly infectious things like bacterial adenitis, mycobacterial infections, viruses, toxo, and then a whole slew of other infections. But you don't want to forget the lymphoma and inflammatory etiologies. Kind of looking through for this case, I was kind of surprised that there's not a great diagram of how to approach the differential for febrile lymphadenopathy. And I kind of just came up with 3 questions that I think anytime you see this patient, you need to have in mind. First, I think it's really important to determine if you think it's infectious or non-infectious. And that was one of the first things all of the discussants talked about, like given the acute to subacute presentation, generally healthy otherwise, really made it seem more infectious, but given age, keep a non-infectious etiology on the back burner. The other important consideration is immunocompromise. Of note, almost all of the infections, with the exception of Yersinia, are more likely to present in someone who's immunocompromised. So it can change your differential slightly if someone's not immunocompromised. And then finally, as we honed in on quickly in this case, it's all about exposure. Oftentimes there is, if there's a disease vector, that's what you want to hone in on. You want to get as much information as you can from the patient or collateral sources. So what about plague? Can't talk about plague without talking about fleas. It was really fun to find out a little bit more about the history of plague. It's actually been detected in humans as far back as 5,000 years ago. So it's been with us for a while. It's been responsible for at least 3 pandemics, most famously the Black Death in Europe, resulting in up to 6 million deaths. Prior to that, there was a pandemic in, I believe, the Mediterranean in the 6th century, and then another pandemic in the 1800s localized in China, all due to plague. Currently, it's endemic everywhere in mainly flea and rat populations with fewer human cases. Fleas do tend to be the main vector. But again, I think as Evan mentioned, it's all about rodents and mammals. Over 200 mammalian hosts have been identified. The important thing about plague is Yersinia Pestis is developed from Yersinia tuberculosis, which was an enteric gut pathogen in humans. And in its evolution, it lost the ability to survive in the human gut and gained a couple plasmids that made it more virulent and immunogenic. So now it lives in fleas, but infects mammals of all kinds, especially humans. Again, it's a gram-negative coccibacilli. It avidly grows in most cultures, so it's not surprising that we got the culture data back so quickly for this patient. And interestingly, it has a very small infectious dose. In smaller mammals such as cats and dogs, it's been theorized that as little as 10 organisms can lead to lethal infection. Once it's inside of a human host, it survives and replicates within macrophages. And due to its effects on the inflammatory cascade, it is frequently complicated by DIC, multi-organ failure, and peripheral gangrene. So in the United States, it's mainly endemic in the Western United States, especially in Colorado. I know we talked briefly about hantavirus earlier in the case, and I worked with an ED physician in medical school who always liked to talk about there has not been a documented case of hantavirus in Colorado for quite some time. That tends to be slightly more centered in New Mexico, whereas plague is in New Mexico as well as Colorado. So in Colorado specifically, there have been 14 cases in the last 10 years with 2 deaths. In 2014, there were actually 8 cases, 4 with primary pneumonic plague, all related to exposure to a single ill dog. Just of note, I think it's impressive how ill these patients get. One patient who was previously healthy was intubated at the Denver Health ICU here for 12 days and took over 5 months to recover completely from the respiratory standpoint. In 2015, there were deaths from the plague here, and and this was a case report about that patient in the Denver Health ED by some of our own near and dear staff. And then this year in Colorado, there were actually 2 cases in Grand County and La Plata County, the ones with stars. And then the 4 other counties, Jefferson, Broomfield, Adams, and Elbert, all have plague activity noted in rodents, largely prairie dogs. So finally, kind of what does it look like in our patients? There's kind of 3 main forms. Most commonly, it's bubonic plague, which is most likely what this patient had. Direct inoculation leading to lymph node involvement, typically presenting with sudden onset of fevers, chills, headache, and weakness, which, reading back to his initial triage notes, is exactly what our patient complained of. Next most common is septicemic. So these are patients who actually also had a direct inoculation, but never present with a bubo, instead present with severe systemic illness and often experience complications such as DIC due to delayed treatment, and fibrinogen buildup in the microvasculature that can lead to this dry gangrene. And finally, I think all of us are always most concerned about pneumonic plague. Fortunately, it's the least common form, representing about less than 1% of cases, either from primary inoculation via, for instance, if this patient had inspired respiratory droplets from the cat, versus secondary pneumonic plague, which this patient may well have had after embolic phenomenon to his lungs. And then, so finally, what do you do for suspected plague? I think the first thing is, just like Hoda mentioned, having a high degree of suspicion and protecting yourself and other providers with appropriate PPE. Again, fortunately, in the time of COVID, droplet precautions were uniform, and we likely were able to minimize any risk to providers. The other important thing here is to make sure you let the laboratory staff know if you're concerned about plague, because there have been many documented cases of transmission and fatalities to lab staff who were exposed to the pathogen in cultures or blood. And then contact your local Department of Public Health. Here, obviously, that's the Colorado Department of Public Health and Environment. In addition, you want early antibiotics. Aminoglycosides are first line. And then consider post-exposure prophylaxis with either doxycycline, levofloxacin, or Bactrim to anyone who is exposed without appropriate PPE. Unfortunately, this patient was in the ICU for several days, but has recovered and is still doing well.
Amelia, I wanted to add a quick thing because it was discussed last year. We had another case, I think, at university. In hospitals that don't have a big database for their cultures, as we do at university, like in the Denver area, this can get mistaken with some other species, specifically the one that was missed for a while was Pseudomonas luteola. Yes. And a patient was transferred here, and days later they were like, okay, this doesn't make any sense, and they ran the cultures here and it came back as Yersinia. So something to think about when the cultures don't match what we think about.
Exactly. Thank you so much for bringing that up, because that is a tremendous part about the delayed presentation that can often lead to more serious consequences and morbidity and mortality. Because viral PCRs or the PCRs are not reliable. Wonderful. Well, thank you guys so much for all your participation. I know we want the applicants to stick around. We've just got a few closing remarks for you, but residents are welcome to